Myasthenia gravis, just the disease you've been wanting to learn about, I am sure. So, in a nutshell, we have this condition, which is acquired autoimmune disorder characterized by weakness. The weakness usually starts in the center of the body and then it progresses outward. But it is the most treatable neurological disorder of the neuromuscular conditions, and so that's a good finding. There is a couple of different causes, but about 33% of the cases are caused by the thymus gland, which the thymus gland is important during your younger childhood, but it really stops contributing after you hit puberty, and it just kind of sits there, that organ. So they have found that when they remove the thymus gland, that the myasthenia gravis symptoms actually go away in about 33% of the cases. Now, onset is mostly insidious, meaning it takes a while and a lot of patients get misdiagnosed. However, it can actually occur with a rapid and sudden onset. In fact, some patients have even died with this. And once you get the disease, if it's not caused by the thymus gland, you literally will have it for the rest of your life, and you'll have periods of exacerbations and times when you have very little signs and symptoms of myasthenia gravis. And as you see here, the disease is usually progressive. It is usually progressive. And if you read in your book, you will note that the initial symptoms of myasthenia gravis are usually related to cranial nerve palsies that control vision. So they'll start having gaze weakness, and it can be unilateral or bilateral. There are a couple different types and grades and categories of MG. That's not really necessary to know at this point, but in general, we just have a problem with the neurons. Our receptors are down there for acetylcholine. These are the excitatory neurons. And for whatever reason, one or the other, maybe 33% of the cases we know, but we have this antibody that attacks the receptors. So our acetylcholine can't get down and excite the muscle like it needs to. All right, some of the incidents can occur in men at any age, but it does occur in men most, and it can occur in any race. So a couple of things that could trigger an exacerbation would be a thyrotoxicosis. This is whenever, well, as you know, hyperthyroidism. Infection can stimulate a occurrence, pregnancy that stresses out the body, and anesthesia. Now, okay, the signs and symptoms that you're going to see early in the disease are a little bit different than what you're going to see late in the disease. So please pay attention to the categories here. The early sign and symptom you're going to see is difficulty chewing and swallowing. In fact, they're going to have some hypophonia, or like a weak voice, and they're going to have a nasal twang. And I'm going to give my best impression of this, but the person is going to talk like they're talking through their nose, and they're very, very weak, and their voice can't project. I have a video here. I wonder if I can get it to play. Nope. I'll just have to hyperlink this in the notes so you'll be able to click this. Alright, so as the disease progresses, we're going to have a worsening of the central muscles, and they're going to get very weak, particularly after repetitive use. So if they're walking, their muscles in their legs are going to get extremely tired very quickly because their acetylcholine is going to get all used up. They're going to have extreme fatigue, and rest is actually not going to help much. They're going to continue to feel the fatigue. They're going to have ptosis. This is when one of their eyes or both of their eyes kind of droop. They kind of have a sleepy appearance. Diplopia, which is double vision, and they're going to have dysphagia. G means gut. They're going to have trouble swallowing. Dysphagia. This is the mask-like face that somebody's going to have, and we know this as the myasthenia gravis snarl. They kind of have, and this is just because of the muscle weakness in their face. They're not angry or anything. Oh goodness, I gotta sneeze. Okay, I sneezed. I'm better. Their head is also going to bob. Gonna point it out again. They have central weakness, and so their neck muscles are not even strong enough to keep their head up. These symptoms may last a few days, they may resolve and then return weeks later or maybe even months later, and so it's very hard to diagnose this at first. But as it progresses and it gets later and later, all muscles are weakened, and this is after kind of a person has had this for years, and they might even be bedridden at this point because they can't walk, they're so weak. But respiratory function will be affected. They'll be on a ventilator. They may have a trach. They'll have a loss of bladder and bowel control. And this right here, take a guess, consciousness. Their mind is good all the way through this. And it's a unfortunate thing. I guess if I had to think what would be a horrible thing about this situation is that they're conscious of all of their deficits. But knowing that it's a central weakness, what do you think their posture is going to be? Poor. Hopefully you said poor. And all of their weakness is going to be in their proximal extremities. So like their shoulders are going to be extremely weak. Their hips are going to be extremely weak. Not so much the distal parts, such as the hands and the feet. Another characteristic here is, I don't know if you can really notice it, Alright, so this is a rare disease, as I mentioned earlier, and is often having a delay in diagnosis. The patient that I mentioned earlier that we were talking about had, or did I mention it? No, I didn't. Okay, let me mention it now. A student and I were taking care of a patient who had myasthenia gravis, and the patient mentioned that she had repetitive lung infections over and over again from when she was 15 all the way up to 19, and she came into the ER again. She said it was kind of a common thing for her to come into the ER for that, and they had a travel physician from New York, and he took one look at her and looked at her history, and he said, I'm going to give you this med. I'm going to give you this medication, and I'm going to see how you respond. And so what he did is he actually did a Tinsulin challenge test. A Tinsulin challenge test, blah, blah, blah. What is this test? I'm so glad you asked. What they do is they actually give you a little bit of neostigmine bromide or even hydrophonium chloride, otherwise known as Tinsulin, and this actually inhibits the breakdown of acetylcholine. And so when you are given this drug, you actually have a tremendous amount of acetylcholine floating around, and a person who has got the acetylcholine problem will positively respond. In fact, the patient that I was telling you a story about, she actually said for the first time she could breathe. In fact, the doctor said after he gave her the drug, just minutes after, he goes, okay, I want you to cough. And she said, oh my God, I could actually take a deep breath and cough. She goes, and then it went away. In fact, for about 4 to 5 minutes, your patient's going to feel like a new person. But then it goes away. And when a patient responds like that, that means they have MG. It's the most common test to test for MG. Now, which one of these would be the best in diagnosing and the most sensitive in diagnosing MG? Eeny, meeny, miny, mo. That would actually be this one, the repetitive nerve stimulation test. Repetitive nerve stimulation test, the most common test. This is to reveal a decremental response to stimuli. So they'll actually stimulate, as you can see here. No, this one, sorry, this one here. So they'll stimulate the nerve and they'll continue to stimulate it. And so what we're actually going to see is the muscle get less and less and less responsive. So most common right here. Now, let's say that this comes up negative, this comes up negative, but all the signs point to this person's, I mean, come on, they've got to have something. It looks like MG, it walks like MG, but they're negative here and they're negative here. Well, let's go ahead and do a single fiber EMG, which is actually what I've got right here. So this is whenever they can diagnose almost all cases of generalized and ocular MG. And so when we do this, we want to make sure that we tell the patient that they're going to feel the stimulation, like kind of like you're touching an electric fence, but it's harmless. We need them to remain completely relaxed, and they're going to stimulate the muscle this way. So most sensitive, right here. Most common and most used here. The quickest and easiest, right here. The other tests are very good too, to try to test for MG. Ever thought why they did the thyroid hormones? For neuromuscular status, why do we need thyroid hormones? Because if you think about it, thyroid toxicosis, that was one of the reasons for developing MG exacerbation. So let's check out the thyroid hormones to see if they have too much, T3 and T4. Why do a chest CT? Why do an X-ray? Well, we're checking out the thymus gland, believe it or not. And also you could be looking for pneumonia. But let's do one of those. And this is also another blood draw you can do. It's positive in about 80 to 90% of patients who have. Some of the complications that can arise from having this condition, the first one being a myasthenic crisis. This occurs when a patient has too little of the drug. Maybe they've skipped some doses. The drug that we actually give in the tinselin test, the patient will take a pill, little bits all throughout the day, maybe like 4 to 5 times a day. But the exacerbation can occur when they have too little of the drug, and it can occur if they have some type of infection. Sometimes patients will have both, and that can ensue a myasthenic crisis. And there's a great table, page 44.1, that kind of describes what occurs in a myasthenic crisis. Their blood pressure will go up, they'll start having bowel and bladder incontinence again. They won't be able to swallow it all. And if we are to do the tinselin test with them, giving them a large dose of the drug that's supposed to help them, then we'll notice symptom improvement. It will be like instant. Now, let's just say we go to the other extreme and they have too much of the drug. That is also known as a cholinergic crisis. This is just as much of an emergency as this one. Repeat that. Both of these are medical emergencies for patient. And the priority is making sure they have adequate respiratory function, and really both of those. So we are really, really worried whether it's the myasthenic crisis or the cholinergic crisis about their respiratory function. And here I have here a list of all of the things that can happen. As you see, they're all respiratory related. But in the cholinergic crisis, they will be completely flaccid. Yes, they have too much cholinergic drug. Won't they cholinesterase? Their muscles will not be stimulated to move. They are going to have super wet mouths. In fact, probably the word for it is hypersalivation. They're going to slobber excessively. This is not a good thing. They may have abdominal symptoms such as cramps, vomiting, maybe diarrhea. Their vision's going to be blurred. In fact, they may not be able to see, like their eyes are going to be super dilated. And when we do the tinselin test, they're going to get worse because we're actually sometimes not sure if somebody is in a myasthenic crisis or a cholinergic crisis, but they get worse is the main thing here. So what are you going to give them? Atropine. Very, very good. Give them atropine, 1 milligram IV. You can even repeat that. We want to make sure that we have an ambu bag handy because we may have to ventilate this person. May have to ventilate them. Okay. I think that's about it. Yeah, and oh, also, I was thinking about this. Make sure to keep a ambu bag at their bedside at all times. Keep an ambu bag or a bivalve mask, whatever you want to call it, at the bedside at all times. They need oxygen and they need suction because they're at risk for going to either crisis. Let's talk about drugs that we want to give this person. In fact, I've got a picture here of somebody who just before he was taking his med and then after he took his pyristigmine. This is a very, very important drug that we must give on time, all the time. Doses may change. They may go up 1 week and they may go down the next week. And so what's important to know is that you give the drug prior to eating, and in about 45 minutes, maybe even 1 hour after the pill, they should begin eating. And the reason for that is that it can help improve their ability to chew and swallow food. Now, some patients will get GI distress when they're taking this, so they can give a little small amount of food and then have their big meal about 45 minutes afterward. Let's see, if somebody is in PO and they need to go to surgery, are you going to give this pill or not? I'm hoping you're saying yes. In fact, we would never want to put this body under stress without the pyridostigmine in their system. So if they're in PO, give it. You can give it a small sip of water. Now, lack of these meds can cause the signs and symptoms of myasthenia gravis, myasthenic crisis. I kind of mentioned them, but I'm going to fill in the blanks here. Tachycardia, tachypnea, elevated BP, poor urine output, and here they'll actually have bowel and bladder incontinence, and they'll have absent cough and swallow reflex. Tachycardia, tachypnea, which is too fast breathing, elevated BP, poor urine output, bowel and bladder incontinence. And then this one is absent cough and swallow reflex. So, let's say we're doing what we should and we're giving person this. Don't forget, you can go to the other extreme and indicate a cholinergic crisis. They're going to have increased weakness, sweating, salivation. Their mouth is going to be super slobbery and wet. And we need to give them that, you can actually do plasmapheresis, but we can also do IVIG, which is IV immunoglobulins. And this actually helps reduce and gives them, reduce the antibodies attacking the acetylcholine receptors. Immunosuppressants, mentioned that one. I believe teaching for the myasthenia gravis drugs would be on page 922. I think it's chart 44-5. I would definitely like to check that out if I were you. We begin talking about ALS. This is a very unfortunate condition to have. It can be genetic with some environmental and viral factors that come into play, but this is a lower motor neuron disease, which unfortunately leads to death in about 3 to 5 years. The onset is gradual. It doesn't just kind of happen like maybe myasthenia gravis would, but the person will have some muscle weakness, some muscle wasting, and even some spasticity. They'll start having some muscle spasms. Now, when you get this condition, your sensory and autonomic nervous system is not involved, so generally you have bowel and bladder function toward the very end. However, patients do have some cognitive and behavior dysfunction. Now, unfortunately, most patients die within 3 years of diagnosis, and this is due to respiratory failure that ensues. It's chronic, it's progressive, and it is debilitating. And is there a cure? No. This disease gets its name from the famous baseball player, Lou Gehrig, who began having this, while he was playing, actually. He was kind of in the peak of his game. And it does occur about in males who are 40 to 60 years old is the peak time. Here he was actually given a speech about him having to retire right after his diagnosis. He said, "Fans, for the past 2 weeks you've been reading about the bad break I got. Yet today I consider myself the luckiest man on the face of this earth." And so he was referring to how he had the opportunity, despite his new diagnosis, to have played. So he actually had a very positive impact on this disease. That's why they named it after him. And he subsequently died about 3 years exactly after this speech. There's, once again, no known cause, no known cure, no specific treatment plan, and no standard method of progression. There's even no standard method of prevention when you get this disease. Anybody know who this guy is? This is Stephen Hawking. He's actually a famous professor, I believe. Oh goodness, Harvard? No. He's He's an English theoretical physicist and a cosmologist, and he is the director of research at the Center for Theoretical Cosmology at the University of Cambridge. So quite famous person because he actually has ALS. He has been living with it for 30-something years. From what I understand, he was first diagnosed when he was 21, and he was not expected to see his 25th birthday. They actually made a movie about him called The Theory of Everything. But he came down with ALS, and they have no reason why. They can't pinpoint it, but he's still alive today, 30 or maybe even 40 years later. So, some of the early signs and symptoms actually start from the distal part of a human, of the body. So, unlike MG, things will start happening in their hands and in their feet. They'll have dysmetria, kind of like a stiff and a clumsy gait. And so, they will notice this, and then they will have these twitching in their face, maybe even tongue atrophy. They won't be able to talk, and that results in dysarthria, not being able to articulate speech, and they'll have dysphagia, not being able to swallow appropriately. Things get stuck in their throat. Maybe they'll choke a few times. They'll aspirate. So these are the early signs and symptoms. Now, remember how I mentioned they have some cognitive and behavioral dysfunction. The person will have this emotional incontinence. One moment they'll be happy, the next second they'll be sad. Kind of like a stroke patient. Right brain or left brain? Hoping you said right brain. Some of the common findings would be the unexplained weight loss, and this is directly related to somebody having trouble swallowing. The ALS complications, generally they are respiratory related and skin related. So think that if you can't clear your secretions, you're going to have respiratory tract infections. You're at some point going to have to get 2 feedings, but before then you might have problems with aspiration. Injury, this is because you may fall, because your legs are going to get weak and you're going to be clumsy. This is actually a picture of a patient with ALS using a communication board. He actually just uses his eyes and he will type out things to say. Pulmonary embolism, this is because patients are, immobile and clots will develop in the legs. All right. At this time, there is only one drug that is approved for a patient, and is called riluzole, also known as Rilutech. That is the only drug that has been shown to help slow the progression. It doesn't cure anything, but it can slow the progression of ALS. The patient wants to make sure they take this on an empty stomach, and it can damage the liver. So we're going to be monitoring, as you guessed it, liver enzymes. This is not necessarily a painful condition. You'll have muscle atrophy, but occasionally patients will complain of pain just related to their immobility, and so we might consider giving them some MS Cotton, which is a long-acting morphine, or Tramadol. Usually they'll go with that one first. Now, if they do have muscle spasms, such as they're starting to get contracted and somebody's doing passive range of motion and they'll have muscle spasms, you can give them something called baclofen. And this other one, tinzanidine. I don't see that one as frequent. I usually see baclofen a lot, or even Flexeril. Now, they are going to have problems with swallowing, so they're going to continue, though, to produce saliva. So at some point, the doctor will order atropine sulfate, just like as we gave atropine IV to a patient with myasthenia gravis. We're going to give it to a person who has excessive secretions. You're going to do like little drops under their tongue, and that will help dry them up. You want to give them guaifenesin. This is actually an over-the-counter drug. This is to help break up and mobilize any secretions that they may have in their lung. Oxygen, I mean, it's kind of important, but I guess it is a drug. You know, we'll talk about it. And sleep disturbances. We can do a few tests on a patient, but diagnosis is solely based on the clinical findings and in conjunction with some of our motor and sensory findings. If we were to do a creatinine kinase, this is a enzyme that gets released from muscles when they're damaged and or atrophied. This is going to be a little bit elevated. We can do a EMG on somebody, that electromyography, and so we're going to see that the person has extensive jitters and fasciculations, which are those twitches. The best thing to do would be a muscle biopsy. This is not like the best thing to do to diagnose ALS, but it does help show that the fibers are actually some interventions we're going to do for somebody. Get that advance directive. Not saying that's the number one thing you need to do, even though I have it first. Maybe the one in red is kind of important. But knowing that the prognosis is poor, an advance directive is critical, because you don't want to do anything against somebody's wishes. Self-determination, you guys. Let's support ventilation. This is done through respiratory therapy, coming in and giving, you know, maybe Duonems, albuterol, maybe Atrovent, or ipratropium. We can put somebody on a BiPAP, that's that non-invasive ventilation, to help somebody breathe. We actually can do a diaphragmatic pacer. I've had a patient who had one of those. So it kind of paces the, and sends an electrical shock to the diaphragm to help complete the breath that somebody is initiating. It's good, but it doesn't slow down the progression. It gets worse and worse, and then at some point the pacemaker doesn't work. Suctioning. We're going to more than likely have a trach placed in this patient, and so suctioning is extremely important. Not doing it routine. You're supposed to do suctioning PRN. That's important to know. Suction PRN, not like every 2 hours. Sometimes it may be every 2 hours, but just suction PRN. Let's see. Speech therapy comes up with a communication system. PT and OT preserves whatever movements we have left. And our dietitian, they want to make sure our patient has enough fiber and fluids. In fact, anybody who has a PEG tube, this goes for whatever disease, they must get fiber and they must get fluids through their PEG tube, and your dietitian estimates their daily rate that they need. And of course, make sure to conserve their energy, sort of cluster what you need to do, get in and get out, and quit bothering them. We're going to perform passive range of motion and making sure they do as much as they can for themselves. But at some point, you're going to have to help them. Assistive devices are an absolute must, and case manager and social work can make sure that the person gets these in their home, because they are kind of costly, so they can actually, if a person has insurance, put them on some kind of. Anybody recognize this fine face right here? Montel Williams, the famous host of daytime TV. And how about this guy here? I know we all know who she is. This would be Jack Osborne. Both of these people have MS. Yep. Both of them were diagnosed to have MS, and this disease is the leading cause, actually, of neurological disability in young adults, where normal life takes for it. They're trying to live normal life, and unfortunately, this disease takes forever to diagnose because symptoms are very, very vague, such as fatigue, weakness, and vision changes. A lot of times, patients are just told that they need to get more sleep and they need to, just de-stress their life. But in all actuality, they have MS. In fact, initial findings can be so vague that a person is not diagnosed for several years. And patients find this distressing because you basically have all of these problems, nobody can give you answers, and you just feel like you don't know where to turn. And it's very depressing, actually. This disease has the stages of going through relapses or exacerbations. In fact, the most common form of MS is the relapsing and remitting. You can live a normal life, like you actually, if you manage it well, you can get to a normal life expectancy. However, it must be managed well. The disease can progress, and the durations and frequencies of the multiple sclerosis flare-ups can become more severe over time. I don't think you guys really need to know the different types of multiple sclerosis, but their name implies their meaning in general, such as the relapsing and remitting MS. It's the most common, so we'll kind of focus on that one. Anybody can think of another condition that has periods of exacerbation in the neuromuscular system? ALS? And try again. How about myasthenia gravis? Ding, 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 ding. Very good. All right. So this right here is a 48-year-old female, lives in Massachusetts. Anybody want to take a guess who she is? Oh, I'm actually forgetting her name. It's Mitt Romney's wife, Mrs. Romney. She was actually, like I said, diagnosed at 48, but typically people are diagnosed 20 to 40 years of age. They will live in colder climates, so maybe that can help you remember. She lived in Massachusetts, that's why I put her picture here. The Northeast, the Northwest, that's a cold climate, and the Great Lake region is where they do see a lot of cases of MS. They're not really sure, but they think it could be viral. Not really sure. It has been shown to be genetic, where if your first degree relative gets it, you may also get it. There are a lot of different factors that trigger relapses in this condition. Some of them, well, they're listed in your book, but believe it or not, physical injuries, say you have like a trauma, emotional stress, pregnancy can trigger this, kind of like MG can be triggered by pregnancy, so can MS. Overexertion, temperature extremes, like if it's super hot, even getting in a shower, like a super hot shower or like a sauna, they can have an MS exacerbation. And like MG, if they have a virus or an infection, they can have another relapse of multiple sclerosis. Oh, MS often, excuse me, MS often looks like a couple other neurological diseases, such as like chronic fatigue syndrome, thyroid disease, syphilis, maybe even spinal cord compression. This is kind of why it makes the diagnosis so difficult. But early on the disease, we'll see something called Udhoff sign. This is a temporary worsening of vision, and it only occurs when patients have exerted themselves or in situations where they are exposed to heat. That's called Udhoff sign. So it's a temporary worsening in the vision. It's kind of important. Now, fatigue is the most debilitating manifestation of MS, and unlike other patients, fatigue is associated with temperature, like they get too hot or even too cold. Fatigue is the most debilitating manifestation, and it's associated with temperature. Patients will have pain or paresthesias, especially in their lower extremities. This is why they think it might be a spinal cord compression problem. They'll have double vision, scotomas. Anybody want to take a shot at what scotomas is? This is when they have decreased peripheral vision. Well, changes in peripheral vision. It's usually decreased, but they'll have changes in peripheral vision. They'll have decreased visual acuity, like it will be really hard to see something, and they'll not be able to discriminate. They can discriminate colors, but from one object to another. Nystagmus, this is whenever your eyes kind of jitter a little bit to the right and to the left, so they'll have nystagmus. Another early signs and symptoms of multiple sclerosis is muscle spasms. So they'll get really twitchy and have pain associated with this. Now, we will also develop something called scanning speech. Scanning speech is whenever you have these long pauses in between the words or these syllables, and they will continue to stop at certain places. I promise there's nothing wrong with your connection. I was just giving you an example of scanning speech. So we need to make sure to be patient with these people, because they will talk in certain parts. So, scanning speech. Now, we will, in addition to have scanning speech, slurred speech. Excuse me. Dysphagia, mood changes. Who else has mood changes? Was it MG or ALS? If you said ALS, you are correct. Another thing that's interesting is they'll have intention tremors. So this is when their hands, when they're at rest, have no tremors, but as soon as they try to reach for something, they'll start to shake and tremor a little bit. And they can be fine or coarse tremors. They will have bladder and bowel dysfunction. Excuse me, gosh. Do you remember what other disease has bowel and bladder dysfunction? How about MG? Good, you got it. At least I hope you did. And that would be late MG, people who have later stages of diseases. They also will appear clumsy, just like our people who have ALS. As you notice, I'm trying to draw some similarities, and I'm trying to explain the differences. So you'll be able to understand this disease, from the other ones. Sometimes it can help a little bit in trying to study and learn all this. All right, and here in late changes, we're actually going to start having some cognitive changes. People are going to have memory loss, impaired judgment. They're going to be very difficult actually to be around in the later stages of multiple sclerosis. Let's see. And impotence. They're not going to have a problem with libido. Libido is going to be fine. Their sexual drive is not affected. For this disease, there is no conclusive lab test. Diagnosis is solely based on clinical findings, maybe some imaging or laboratory findings. So when they do a lumbar puncture, their cerebrospinal fluid may show some white blood cells and even some protein. And if they were to check a total immunoglobulin level, it might be elevated. They can do a head CT. This is going to reveal some plaques in the head. And if we were to do an MRI, which is the most sensitive, that goes right here, it's the most sensitive diagnostic test method for detecting this disease. It's going to show active plaques inside the brain. We can do an electromyography again, but this may be grossly abnormal. It's going to show abnormality, but it only is useful in people who have the advanced form of the disease. This was the bad bladder and bowel problems I put a picture there of. All right, so you need symptoms, you need a CT, MRI. All right, multiple sclerosis complications. Remember, they have that dysmetria. Anytime you know dysmetria is a problem for the disease, such as an ALS or MS, injury from falls is huge. Injury from falls, they're going to fracture their hip, and then we're going to have to do a total arthroplasty of the hip, probably through an open reduction. Put it all together for you. UTIs, that's going to be a common problem with these people. Constipation as well, because they're not going to have good bowel and bladder movements. Probably their food choices are going to be poor as well, since they can't swallow. Pressure ulcers are going to actually be a problem with this group. Sexual impotence, because remember, they have no problem with libido, only function. Optic nerve atrophy, their visions are going to get worse and worse. They may even become legally blind. This is through multiple exacerbations, by the way. Just throw that out there. They can have emotional liability and depression. This is very challenging for family members to have to try to, support this person as they're going through all their multiple. One or more drugs are recommended for multiple sclerosis. Drugs are used to treat and control the disease, also to decrease specific symptoms and to slow its progression down. So what we have here on the left-hand column are drugs that were given to help try to modify the course of the disease, particularly this interferon beta 1A, or Avonox. The first dose is usually given under medical supervision. Reason being is that they are likely to have a reaction, such as an anaphylactic reaction under the first dose. So they're given, at the doctor's office. The rest the person gives at home. For both of those, really, we need to make sure the person reports the signs and symptoms of infection. This one I've seen, actually, it is the first med that's approved orally for multiple sclerosis, and we wanted to monitor the pulse for about within the first 6 hours of giving this drug. And the reason being is it can cause, as you see here, bradycardia. Also can suppress the immune system, kind of like the others. Now, I kind of don't want to go into all of these, but we give IV steroids. We're at risk for, breaking bones. We have to taper doses. You're not allowed to stop steroids immediately. Laxatives, just because they have constipation problems. They do have spasms, so let's give them some baclofen. Or those drugs again, they keep coming up, huh? Ooh, we can give baclofen intrathecally. In fact, when a lot of patients, not a lot, some will actually get a pump that's implanted into their body, and it will give slow doses of baclofen over time. Your spasms have to be pretty bad, just saying, to get the pump. A lot of times you just take a pill. All right, depression. This one right here, this is an SSRI. This is great for the pain that they may feel and the emotional labilness. Oxybutynin, this is a anticholinergic, and if you know anything about anticholinergics, you have to watch for this side effect. I mentioned it before, but the side effects are can't pee, can't see, can't spit, can't shice. But the bladder incontinence that patients have, we can give them this drug here. The big thing is that it doesn't go too, the drug doesn't work too much on patients. It can happen. It can. So, to assist this person, frequent rest periods is the name of the game, because fatigue is their most debilitating symptom. We need to avoid overworking and de-stressing their life. Aerobic exercise is actually very effective. This right here is actually a painting of some visual imagery listed here, which can help with pain management. Distraction can also help. In fact, I know a couple of times, you use this by not even thinking about it. You'll turn on TV, you'll talk to people, and sometimes they can forget about the pain that they're in. We can give them electrical nerve stimulation, such as a TENS unit, that can help with the spasms. Localized heat, do make sure that we put a barrier between their skin and the heat. This is for the muscles achiness that they may. Some other interventions we can do is basically monitor and manage the symptoms. We may eventually need a wheelchair for this person. So at some point, they're going to lose their ability to walk. Maybe. Behavior problems are completely common, so teach family to work with the person and even maybe do nonverbal signs or cues when a person is behaving inappropriately. The speech language pathologist can definitely help with swallowing, picking and choosing directions for them to turn their head. We want to remove scatter rugs. Everything must be clutter-free because they have dysmetria. Now, if their bladder incontinence is bad, we can obviously do the one drug. They may have the other extreme of bladder retention. We can do self-catheterization, teach them how to do it, or even put in a pacemaker. And they are at risk for UTIs, don't forget about that. So a lot of times they'll do prophylactic antibiotics. That means antibiotics. Cognitive behavioral therapy, this has shown to be very productive for patients with MS. Use scanning techniques. Now, they're going to have scanning speech. That's, remember, where they talk in little patches of words and syllables. However, scanning techniques is supposed to be for vision impairment. In fact, see this here? This teaches a person to look across the room and find different things, or they can kind of do like an X pattern. So teach a patient to use scanning techniques, and this is to help with their scotomas, their peripheral vision problems. We're going to implement eye patches. This is actually very useful for blurred vision. it actually kind of solves it really easy, and it helps the one eye be dominant and be used for seeing versus both eyes trying to see things. The occupational therapist is usually the one who initiates this. Sexual counseling for the impotents. We may even have a patient discuss the prosthetics or a stimulation device. Avoid temperature extremes, hot showers, super cold days, and a person needs to kind of diary. Last but not least, diet interventions. Maintain a nutritional management program. They're going to be constipated. Let's look at getting some fiber in their diet. Thick liquids. They can't swallow, well, at least at some point they're going to have swallowing problems. Let's make sure that their liquids are thickened. They can get it down better. Foods need to have gravy on it. They need to be pureed maybe at one point. And worst case scenario, we need to be giving somebody PEG tubes. They need to know the signs and symptoms of being too full. You know, they're going to have a little bit of diarrhea maybe from the tube feedings. Put some fiber in there. This is the diet we want them on. High fluid, high fiber. That's what we need to walk away from this diet interventions. High fluid, high fiber. Okay, everybody, thank you for listening to the PowerPoint. If you have any questions, feel free to use the discussion board, and you can email me, or you can do both. At some point, somebody will answer you. Hope you have a great evening, and I will be reaching out to you guys later.